Remy.
Episode 3, Dr. Shant, let's do it.
Yes. What are we talking about today, Remy?
We are talking about the difference between pain and nociception.
That's a good one, isn't it?
Very important, actually. Very, very important.
All right. So, when it comes to pain, why did we choose the topic pain?
It's interesting. It's probably the main motivator why anyone ever comes to see us.
Yep.
No one comes to see us because they have a movement dysfunction that they know about. They come to see it because it's become a problem.
Yep.
And what they're experiencing is pain. But the difference that we want to get people or help them to understand is the driver behind why that is,
Yep.
as opposed to just chasing the symptom of pain by itself,
Yep.
or chasing the solution, the fix.
Generally, that's probably, I would say, almost every single client. The
Yeah.
first thing they say is, I have done this, this, and this, and then I have this pain, and now I'm fucked.
Yeah, pretty much.
I need help,
Yeah.
right? But what we wanted to focus on is pain is not the target of our treatment. And this is a message that we both try to communicate really well with our clients, is
Yeah.
that pain is an outcome of what has already happened. And fixing a symptom is not going to fix the original problem that caused the pain, right? It's like choosing the cart before the horse, right?
Yeah. Well, it's like if the pain is the tip of the pyramid or the end result, we got to focus on that base. We got to cover our base before we start
Correct.
further up.
Yeah, and like a lot of my clients, they feel quite confronted when I say, I am not going to fix your pain.
Yeah.
But then I explain to them, I am going to fix the cause that resulted in pain. The pain will take care of itself. And pain, I think something that we want to make it very clear and understandable for everyone is there's a difference between pain and nociception. I think it's a common mistake amongst the highest level clinicians as well, getting pain mixed up with nociception.
Correct, and I think it's interesting because, and we'll get into this probably now and probably in another episode as well, but all this talk about modern day pain science, and people bring up, the different aspects of the biopsychosocial model and how we come from probably a slightly different lens to what at least is perpetuated a lot online, right? And it's not to say that pain can't be experienced in different ways for different people, but it's exactly that. It's to be able to take out, okay, what is the mechanical driver of the pain compared to what's the person experiencing? Let's understand that the experience can evolve and change,
Yep.
but the driver is there for a reason.
Yep.
You didn't wake up 2 weeks ago with it, but you did today,
Yep.
and it's from a mechanical movement. There's a reason why.
Yeah, and that's a very good point you bring across, and that will help us, create the distinction between pain and nociception. Is pain is something a person is experiencing. It's a psychological experience based on the information that their nervous system is receiving through the nociception.
Yeah.
So, keeping up with our theme, we always like to define things so we're talking about the same thing when people get into, semantics arguments.
Yes.
Right.
100%.
So, I will start with the nociception, and you can tell me your interpretation of what that is. So, nociception, it's a neurological phenomenon, right? Our nervous system have all these senses that goes out to the other parts of the body, all throughout the body, that recognizes different information. So, for an example, you have your thermal nociception.
Yep.
You understand, you feel hot or cold. There are mechanical nociception. There are chemical nociception, meaning inflammation, right? So the nociception is the senses, they're recognizing what that feedback is, sending that feedback into the nervous system,
Yep.
and then the nervous system is going to make a decision based on that. And as part of the psychological process, the person makes a perception of that information in their head about what the pain is.
Yes.
Yeah. And have you seen like different people have very different relationship with pain?
Absolutely. And that can be due to a lot of different factors. And exactly that. The factor, it's almost like the signal, which is that signal from wherever it is in the body, if we're talking something mechanical, through the spinal cord to the brain, boop, 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 back down, and whether it goes just here or it's going all the way up. And then the interpretation of that, they're completely separate entities. They're completely separate things that are going on here. And absolutely, you will see a great variance. You'll see elite athletes who can take a copious amounts of pain. And then you'll see people who, you know, they walk in the clinic, how's your back pain today? That's a 9 out of 10.
Yeah.
Okay.
Yeah.
You walked in, you look pretty good.
I think the pain scale we need to discuss something. We'll discuss it in a minute.
That's another thing to get into. But the point that I'm trying to get at is that the mechanical driver is something, and then the experience is two completely separate things.
Yeah. And I'll use one of my very interesting experience, right? So I've had 11 surgeries many, many years ago, right? That was from my time in the military and all the things that I have done. But last year, I've decided to go for my tonsillectomy, septoplasty, and adenoid surgeries.
Yeah.
Not a very good idea to do all three at once, but I don't have a lot of time, so I told the surgeon just get it all done at once. Now, those who have done tonsillectomy surgeries probably, let's say, 7-8 years ago, the most common advice they would have been given is after the surgery, have liquid food, avoid solid food, right? Have a lot of Gatorade, ice cream, yogurt, something very soft. Now, that has actually changed, that recommendation. Now, the surgeon told me the day of the surgery to start eating solid food.
Right after, like the day after?
Pretty much. And when I was actually in the hospital, they gave me a sandwich.
Wow.
Right? Now, right after the surgery, I'm pumped with medication, so I didn't feel nothing. I was the happiest guy ever, right?
Chilling.
Of all kind of shit, you know, whatever they put in me, it was like, you know, I was flying.
It's a good time.
But what they explained to me is that I'm actually going to experience more pain, but it's for my benefit. Because the most common, you know, the risk of tonsillectomy surgery, especially adult tonsillectomy, is bleeding and ending up in the emergency.
Right.
That's literally the main problem people experience.
Yeah.
So the research that they have found is once you have the tonsillectomy, you need constant subtle abrasion to stop it from having deep scabbing. Because once those scabs either split or break off, they bleed.
Yes.
But if I have very subtle abrasion throughout the day, it allows that healing to happen without having that big giant scabs.
Okay.
I actually ended up having a very good conversation. We became friends, right, with the surgeon. Like, we ended up having some very good conversation about my understanding of how we approach that in the field of tendinopathy, but we'll make a different podcast on that one.
Yeah.
But the interesting thing is, I had no complications with my surgery. I was in an excruciating amount of pain for a week, but I got really, you know, like I got better very quickly.
Yeah.
Right? Especially adult tonsillectomy takes about a couple of weeks to settle.
Yeah.
In a couple of weeks' time, I was doing consultations and talking to people.
Yeah. And that's so important because maybe contextually different to our field and musculoskeletal pain in injury and movement. However, physiologically goes to show the proof that pain does not equal outcome.
Yes. And pain doesn't always equal tissue damage either.
Correct.
Right? So you have powerlifting experience a lot more than I have.
Yeah.
If you can't handle pain, fair to say you shouldn't play most sports at a decent level.
You're probably not going to get to an elite level in any sport without some degree of pain. That's pushing your body.
And that doesn't mean it's a bad thing.
No.
Right? So, you know, I just did deadlift. You know, Friday's my deadlift day, and I do hook grip. Yeah. How many times you're coaching as well in powerlifting?
Yeah.
How many times you have heard people say, I don't like doing hook grip because my thumb hurts?
It's painful, but it also gets the job done. And again, you know,
if you can't handle that pain, which is your psychological experience, it doesn't necessarily mean tissue damage. It's just a piece of information that your body's receiving and you're making sense of it.
Yeah, yeah.
And if you can't handle it, or for an example in football, if you can't handle a tackle, probably not a very good idea to play a contact sport.
Yeah, absolutely. Pretty
Right.
fair to say.
Right. So now let's get into the way we approach our assessment.
Yep.
Right. So whenever someone comes to, tell you about all of their pain experiences, whatnot, what's the next thing you do?
I ask them their goals. That's probably the next thing I ask. First is, what's the problem?
Yeah.
And then next is, what's the goal? What can't you do which you want to be able to do? And being able to frame it in that sense right off the bat
Yeah.
is, I find, what changes the whole direction of a consult from them leaving and going, oh, hang on, my pain isn't fully fixed the moment I step out today.
Yeah.
And them leaving and going, hang on, I was able to do X, Y, Z better.
Yeah.
Therefore, I'm on the right track. And even just flipping that little mental view of what just happened, even that in of itself has a huge impact.
And that's a very good way to explain to people that we are not actually targeting your pain as a treatment. We are targeting your movement as a treatment.
And there are times when I'll do that. I see a lot of acute cases, and when I have to use manual therapy for a certain task, oftentimes if someone is in acute pain and that's what they want, let's do it. But that's a part of a broader management plan. Which is all designed at, again, the base of that pyramid.
Correct. And in my case, like the first thing I try to explain to, once we have gone through what their problem is and what their goal is, once I start to explain to them the process that we're going to go through, the first thing I try to get them to understand is, I don't really care about your pain. It doesn't mean that I don't want you to get out of pain. But I don't want to be the pain as the focal point of my treatment.
Yes.
I want to find out what caused that pain and remove the cause.
Yep.
So we're not treating the symptom, we are understanding the mechanism that resulted in that pain and fix that. So when I say that to people, they find it quite confronting, but once I explain to them that I will take care of what is causing the pain will take care of itself. And a great lesson that I've learned from Andrew that I also explain to people is, getting out of pain is not always a pain-free process. For an example, activations, which is going to be our next podcast, right?
Yeah.
When people start doing activation, whatever muscles they're activating, it's pretty sore. For a lot of people, they don't know how to create distinction between the two. It's like, oh, now I'm sore in my glute, but my back doesn't hurt anymore. Good.
It's a very good thing.
It's a very good thing. You are using something that you haven't optimally used in a very long time, right? Now, let's go into nociception, right?
Yeah.
So we have a few different types of nociception processes. We don't have to list all of them. Let's go through a few examples of them.
Yeah, right. So, I mean, you talked about thermal, right? We've got our hot cold sensation, and that's something which is an immediate reflex, right? We've got things like our mechanical pathway as well.
Yep.
Our chemical, which we spoke about.
That's your inflammatory
we haven't
process.
spoken about, but there you go, your inflammatory process. So there's multiple different pathways that will go through different tracks through the spinal cord in order to reach where they need to get to in the brain.
Yeah. So let's use thermal as an example, right? Let's go through this whole process. Let's say somebody touches something really, really hot with their hands.
Yep.
So the thermal sensors is going to recognize that.
Yeah.
And it's going to send that feedback through the nervous system
Yep.
into the spinal cord, and then we have 3 different layers of motor control patterns. And the nervous system is going to determine what to do with that.
Yes.
So what's the most common thing that happens when somebody touches something hot?
Boom. Instant jerk reaction.
Instant jerk reaction.
It's like a reflex.
Right. So the information went to the nervous system. The nervous system determined I need to contract certain muscles to move my hand away from the threat. Meaning, let's say if I want to pull my hand away, I am going to send instructions to the biceps to contract and inhibit, I'm using that dirty word, inhibit the triceps to accommodate for that to happen.
Yes.
Right? So that is the neural process. Now, what that person experiencing or somebody else is experiencing from that thermal That's the psychological experience,
Yes.
right? And again, that psychological experience is not what we are trying to correct. What is the easiest way to teach somebody to not touch something hot? Stop touching hot things. And most people learn that lessons really well. But when it comes to mechanical things, it's a little bit different, right? Because it's
Correct.
a motor pattern issue,
Yes.
right? And what we discussed about the few different types of nociception, mechanical drivers, it's one, right? So let's give an example. We were talking about knee pain before. Let's give an example of nociception and the role of other muscles that can play in that.
Yeah.
Yep.
Yeah.
Okay. So let's say somebody experiences pain in their knee, right? And we're trying our best to tie this podcast to the next one, so there's a bit of a continuity to it.
Yes.
So when somebody's saying, when I squat, on the way down, I don't get any pain. But the moment I get to that change of direction phase and coming out of it, I get pain in my knee. Okay, you've already told me what you know. We need to find out what we don't know. So the question is not where does it hurt, but why does it hurt there?
And that's why when someone comes in and tells us I have a sore knee, sure, I'll probably assess the knee, but I'm not really mainly interested in that. I'm looking at what else is going on, what else is missing.
Yep.
There's always a reason as to why something is overloaded in the first place, especially when it's in a movement pattern that's somewhat insidious or has been going, building up.
And something very important that you said at the beginning of this episode, which is you always go back to the problem and the goal. So if the person is telling you they're getting pain in squat and powerlifting is their goal, then you look at their squat pattern.
Yeah.
You see where the movement is breaking down and you fix that.
Yes.
You're not treating the knee pain in isolation, right? Something else I tell my clients is that the easiest way to fix pain, or the most effective way to fix pain, is just send you to a sports doctor. They're going to give you a cortisone injection. Mask the problem with heavy chemicals.
Yeah.
It sometimes works, sometimes doesn't work. But even if it works, maybe for 2 months, maybe for 3 months, you're not going to feel anything. But that pain will eventually come back with a vengeance once that cortisone shot has worn off.
And inevitably makes things worse because we know A, you're probably going to keep redoing damage to that area, but also B, we can get into processes behind it, but what that cortisone is actually doing to that soft tissue, connective tissue.
And I saw you made a post about the centralization of pain.
Yeah, that's a big one.
That's a big one, right? And you're never taught that.
No, hardly.
I was never taught that. Like if you didn't know Andrew, we would have never learned that.
Yeah.
Right?
Yeah.
So I think we can finish this episode with this very good example of centralization of pain, where more pain can actually be better for somebody.
Yeah, 100%. Yeah. And again, this is probably specific to a certain type of injury if we're dealing with something radicular or neural, which is not a somatic cause. So what we mean by that is that it's a pain that you're feeling somewhere, which is really as a result of somewhere else. And most commonly that's going to be from some sort of disc injury or inflammation of the site, which is now sending pain down a nerve pathway. But again, really interesting because they never taught us this in uni. But if the pain in your low back is actually getting worse, but what is further away is starting to retreat and come back and get better, that's a sign that we have less chemical irritation around that nerve or around the disc, whatever the site is.
Or mechanical there. With the disc protrusion, right? So 100%. Like a paracentral protrusion,
yeah,
right?
Absolutely, yeah. Which I found really interesting because they just never really spoke about. Yeah. But I have so many clients say to me, my back's gotten worse. And I'm like, okay, how's the tingling in your foot? Oh, it's gone. Good.
You are actually on the way of getting better.
Yeah.
And I get that a lot. It's like, I don't feel that, that the referral sensation, my foot going numb or, losing power in my foot or sciatic pain that they experience. Before I had no back pain, all that is gone, but I have a lot of back pain right now.
Yeah.
Good.
Yes.
The pain has changed not because we have done something to the pain. We have mechanically done something to correct the pattern in the right direction.
Yes.
And centralize the pain. The more we can centralize the pain, let's go with the radicular pain that we discussed. The further that nerve root is being irritated, the further down the chain you're going to feel the pain.
Yeah.
The closer to the spinal cord, or well, actually in low back we don't have the spinal cord, we have the claudia equina, so the bundles of nerves. The closer it's getting to it, the better you're getting. That's why you're actually experiencing pain centrally, even though it's more pain. Like an example, I use them, it's like if you had 2 out of 10 pain in your foot, but now you have 4 out of 10 pain in your low back, you're actually getting better.
Yeah.
You're on the right track.
Yes.
And it's very important to communicate that with the clients.
Absolutely. It can be very confusing.
Yeah,
if you
and
don't
that's why
understand it.
having that conversation at the very beginning about pain, educating them about pain and the difference between pain and nociception and why we don't get fixated on pain is very, very important.
Absolutely. I like to give the analogy that if I have a patient, okay, if we look at your progression over 12 weeks, but if we look on it on a smaller basis, we zoom into the days, weeks, it's always going to be like this.
Yep.
And that's a part of the subjective experience that you have as a part of the change, even in neurology, if we're talking about the centralization process or other drives, and especially when we're dealing with someone who's rehabbing to performance and still having to push their body.
Yep.
So, I mean, with that, we've gone over a lot today, but at least being able to kind of get towards the fact that pain, again, does not equal the outcome, and that pain and the nociception are 2 separate different things. I think
100%.
that's what we just wanted to highlight.
And yes, pain can affect people's movement behaviors, and there's a great research by Weish and Tracy. But I think that ties more into that biopsychosocial model. I think we need to do a whole different podcast.
Yeah, that's a different
that
one.
topic.
Yeah.
So let's not get too much into that. But the key takeaway from today is don't use pain as the target of your treatment.
Yes.
Find the underlying cause of that pain and fix that.
Yes.
All right. Episode
Beautiful.
3 in the books.
In the bag.
In the bag. All right, that's the one.